Hey everyone, how's it going? Welcome back to the Infatuasian podcast. Today I'm really excited to geek out a little bit today because Chris, you don't know this, but you kind of know this, but I teach high school biology. So I've been talking about the same stuff for 28 years. We talk about cellular respiration, the mitochondria is the powerhouse of the cell, that kind of stuff. So it's pretty exciting for me to talk about things that are a little more cutting edge and a little more exciting. So everyone out there, I hope you're into this too, but I'm going to talk a little bit of science today. We're going to talk a little bit about medicine, data science, artificial intelligence. We are with University of California at San Francisco medical doctor and postdoctoral researcher Chris Williams. Hey, Chris, welcome to the show.
Hey, thanks for having me. It's great to have me on, and thanks for inviting me on here.
Oh, of course, yeah. Side note, we are talking because I met Chris at a really cool event. When was that? About a month and a half ago. It's called the Postdoc Slam, where postdoc researchers at UCSF have to boil their years of research down to 3 minutes, and you get one slide. And Chris made it to the top 10, and I got to be one of the judges. I was invited to be one of the judges because I know some folks over there, and they wanted a high school teacher there. So I got to judge, and Chris made it to the podium. He got third place in the Postdoc Slam, so congrats on that.
Thank you. Yeah, I think one of the things that as researchers we're not perhaps as good as we should be at is just talking about our research in a understandable way. And I think it was great to be able to do that and use that opportunity to reach a slightly wider audience than who I might be presenting to at a conference. So yeah, thanks for judging that.
No, that was great. Yeah, it was good because I could see the struggle of trying to get these really complicated ideas down to 3 minutes in digestible terms. But it was fun. It was we'll talk about the paper later a little bit, but it's about emergency rooms and what's the actual title? Racial disparity in
racial disparities in the acuity score. So how clinically unwell we say patients are.
Okay, yeah. So we'll talk a little bit more about that later. But before we get to that, we like to greet our guests in the Asian way. So, Chris, have you eaten yet?
I have, yes. Thank you. Have you?
Yes, I have. Yeah, good.
Beautiful.
So I'm glad we're both well fed. We're ready to go here. Yeah, can we dig into your roots a little bit?
Yeah, absolutely.
So I'm guessing you're not from San Francisco originally.
What gives that away?
I don't know. Your skin color, I guess. So you're from England.
Yes. Yeah. So I was actually born in Singapore. So I'm half Chinese. My mum's from Malaysian Chinese, and my dad's from the UK. I spent 4 years in Singapore, and then we moved to the UK where I kind of grew up. And so I guess I consider myself very Western because I spent most of my life in the UK, but I have half my family in Malaysia mainly. So,
do you get back there at all?
Not as much as I would like these days. We used to go back every couple of years, certainly since med school, and it just so happens that exams are always in the summer, and life gets in the way. But when I can.
Yeah, that'd be great. What part of London did you? Oh, sorry. What part of England did you grow up in?
A place called St Albans, or close to a place called St Albans. I was in a village actually, but I say St Albans, which is about 20 miles north of London. So between London and Cambridge, give or take.
Yeah, I did a little poking around on LinkedIn. And so St. Albans is one of the oldest schools in the world. It's like over 1,000 years old.
Yeah, I had forgotten about that.
Well, if you're game, are you willing to play a little St. Albans trivia?
Very game. I'm probably going to do very poorly, but yeah.
Okay, so we're talking Hertfordshire?
Yeah.
Okay, so we're talking about St. Albans. It is over 1,000 years old, founded by Abbot Wulshan in what year?
963.
Close, 948. So you gypped him a little bit. Yeah, so over 1,000, almost 1,100 years old.
Yeah.
All right. Now I also saw that you did A levels in Latin, so this should be easy for you.
Oh no, this was a long time ago. Can I just point out?
All right. The school's motto is "Non nobilis nati." What does that mean in English?
That one I do. That born not for ourselves.
Yeah, that's great. Born not for ourselves. So they kind of have an emphasis on service and helping others. Is that kind of?
Yeah, I think. Yeah.
In general.
Yeah, generally.
Okay, but so in over 1,000 years, you can have quite a few famous alumni. One of the ones that I think there's a house named after him is Stephen Hawking. We all know him. All
Yep.
right, so I'm going to give you 4 people. Which one of these 4 did not go to St. Albans? All right,
Okay.
you ready? Composer Tim Rice, he's famous for writing the lyrics to Aladdin and Beauty and the Beast and Evita. Elizabeth, Lizzie Bird, Britain's record holder in the 3,000-meter steeplechase. Evolutionary biologist Richard Dawkins, author of Selfish Gene, also coined the term meme. Or Pope Adrian IV. He was the Pope from 1154 until his death in 1159. Which one of those 4 distinguished English people did not go to St. Albans?
So Lizzie Bird, I know because she's a couple of years ahead of me, and a good friend of mine is a runner as well, and so I know she did go to St. Albans.
Okay.
Richard, oh god, I reckon was it Tim Rice? You said who's the first
Tim
one?
Rice is the lyricist.
Tim Rice.
Yeah.
I reckon he probably did.
Okay.
And then it's a question of whether Dawkins or the Pope.
Pope Adrian IV.
And how recently was Pope Adrian? I'm not very
1154.
Oh, okay. So I'm gonna go for Dawkins didn't, because I reckon I would have known about it if he couldn't how recent it is.
Yeah.
Is that true?
You got it. Yeah.
Oh wow.
So Pope Adrian went to St. Albans. All right. Yeah. The list is long. I could have gone really deep on this list, but yeah. All right. So you did pretty well. 3 for 3. 2 for 3. Not bad. All right. So that's kind of cool. And then after St. Albans, it's off to Cambridge. Yeah.
Yes, that's correct.
What was the plan? The plan was medicine the whole time. Do you come from a line of doctors, like 3 generations in? Or?
No, is the answer. I guess at school, I've never been the person who always wanted to be a doctor since the age of 3. I guess I've always been curious about a variety of things, and I liked my sciences in school, and that was one of the main drivers. Because I remember thinking, I did work experience in law, for instance, as well as medicine, and I think the first work experience I did was in a hospital. Like it was a week over the summer, and I remember thinking that this is all right. I don't really understand much of what's going on, and no 17, 16-year-old really wants to be in a hospital or anywhere working in the summer when it's hot outside. So I left thinking it's all right, but we'll see what else is there. Did a week of law and then realized that, okay, law is not for me because it's lots of reading, shall we say, and more reading.
Yeah.
I can say that my brothers are now a lawyer, so. But yeah, so my family. I'm the first doctor. I mean, I think my dad's the first of his generation to go to university, and my mum's from Malaysia. And it's so they didn't come from very well-educated backgrounds. Per se, formally educated, I guess. And yeah, so not very much not from a long line of doctors. But yeah.
What was your dad doing in Malaysia or Singapore?
So they met in London. They're both accountants.
Okay.
And they met in London, then went out to Singapore, probably to be closer to my mum's family. And that plus, I think there was a job opportunity there. And so it was kind of work/family related, I guess.
Do you feel close to your Asian side at all? I mean, growing up in England, in a town, not really a metropolis per se, but did you feel pretty close to your Asian side at all, or did you kind of downplay it a little bit growing up?
I guess yes and no, in that, I feel, as I said earlier, I feel very westernized almost because I feel like I've missed out on some perhaps Asian culture or heritage because I've not, in comparison, say, my cousins in Malaysia who are very, very much the other side of the coin. And, looking back on things, reflecting back on, say, my childhood, things like trying to fit in more, perhaps it's almost easier to embrace your Western side more than to embrace your Chinese side, being in a predominantly white primary school, say,
sure. Yeah.
or an entirely white primary school, and you do kind of stick out because you're different. And and so it's only, I guess, in more recent years I look back and think that actually, this is a side that I don't know as much about as I know it a little bit about kind of thing, but there's always more to learn, I guess. And I'd love to just embrace that side of things more.
Sure.
Going forwards.
Yeah. So you get your medical degree. Well, you're at Cambridge for what, 8 or 9 years, about, or?
So I was living in Cambridge for 8 years. 6 years of that was med school slash. So med school in the UK is a little different from here in that it's either a 5-year undergrad degree or a 6-year undergrad plus you get a bachelor's in something degree.
Okay.
So Cambridge is very traditional in that you do 2 years of kind of basic sciences, medical basic sciences, and then in the 3rd year you do the same course as all the other scientists who are getting the bachelor's, and so you get your bachelor's after 3 years. And then you do 3 years of clinical school where you're doing clinical rotations in hospital. Mm-hmm. And so it's a 6-year course spent in Cambridge. And then after that, I did 2 years of residency, essentially.
But then California comes a calling around 2022. Is that about right? You moved to San Francisco?
Yep. Basically just over a year ago. Yeah. Is that right? 2022?
Something, yeah, about like that.
Time flies.
Time is flying, yeah, no kidding. And so what drew you to UCSF?
I guess a variety of things. I think by that point, so I wanted to, so clinical training in the UK is very long. It's probably about 8 to 10 years. And I knew that I wanted to split, not to just follow the conveyor belts. And I was very interested in research and have been for some years, both in medical school and after graduating. And I wanted to do more of what I was really interested in health data science, AI and medicine, that kind of research. And so I think about, 2 things. Firstly, I remember my boss, Atul Butte, who's a fantastic guy. I remember during COVID times watching a webinar of his, and I don't know if for anyone who's seen him speak, he's something of a, like, he's both the most optimistic person I know probably and one of the most inspirational speakers. He can really sell something. And I remember hearing him talking about how, I think the phrase was, data is the new soil rather than the new oil. And essentially saying that there is so much data to go around and so many people who can do it, that we're no longer competing against each other in research, say. And instead it's a question of how do we all get together and collaborate and work towards this kind of better medical research future that we all want. And so that was just kind of a wow moment for me of, I really want to kind of work under him. Yeah. And then similarly from a data perspective, so we're very privileged at UCSF to have access to lots and lots of data, essentially. So all de-identified health records from the entire University of California system. So UCSF, UCLA, and so forth. And so this has all been kind of put into place like safely and ethically and so forth, to allow us to do this kind of research. And just on a scale perspective, it means you can do a multi-institutional study. It's all at the tip of your fingertips, basically, because you just have to know how to code in order to access this data. And that was such a big drive for me. So it's the combination of those 2 things, I guess. And the weather in SF, I guess.
It doesn't hurt. Yeah, it doesn't hurt. So we were talking about Atul Butte, director of the Bakar Computational Health Sciences Institute at UCSF. So pretty cool stuff. I'll link some of the websites in the show notes so people can follow that. But yeah, I've never heard him speak, so I guess I gotta watch some of his webinars and stuff. But so you get to San Francisco and you become a postdoc researcher. For those out there who don't know, so once you have a doctorate, you can do what's called postdoc research, where you're working you're kind of in between the PhD students and the primary investigators. You have 1 degree or 2 degrees under your belt, but you're expanding on your research. So you're doing a lot of computer stuff. Did you ever take a lot of coding in undergrad, or how'd you learn how to code?
Yeah, no is the answer. I guess I never thought I'd be the AI guy, is what I always say. And yet somehow 4 years down the line, here I am being the AI guy. I guess I've always been driven by a desire to do impactful research. And that often means doing things at a scale that is large, public health, essentially, population health scale. And I think back a couple of years ago, I thought, well, I want to do this type of research. And what's the easiest way to do things at scale? It's learning how to code. Because if you can do things in an automatic fashion, then you can scale very, very easily. And so I actually started off my research course. One of the main things that started off me down this AI path was when I was looking at the dizziness clinic in one of the hospitals in Cambridge, Addenbrooke's. And we're looking at some of the symptoms that patients with different types of dizziness problems were experiencing. And I basically thought, well, why don't I just do a basic word count of what's condition A versus condition B, what the symptoms are.
Uh-huh.
And we submitted this for publication. And one of the reviews that came back was that this is actually called natural language processing. It's not quite how you do it, and you can do it a slightly better way. And so we looked into that, and that was kind of my first kind of entry into what natural language processing is. And now with ChatGPT and everything 4 years later, and suddenly everybody knows what this kind of field is. And it's quite nice because people understand what I'm doing.
You don't have to explain it every single time. Yeah.
Exactly.
Yeah. Okay. So that's cool. So basically what you're using is machine learning or AI where you're going over medical records in a way, or like you said, descriptions of diseases or symptoms, and you're kind of trying to find patterns?
Essentially, I use statistical or AI tools to answer impactful questions in medicine or public health. So we think about, say, racial disparities within healthcare. How do we identify this at scale? And if we have, say, a few 100,000 patients who are going to the emergency department, then we can use certain regression models as statistical models to look at the odds of, say, being a ethnic minority patient versus a white patient, and whether they do or don't receive certain types of care. That's one side of things. And then I'm also looking from a more AI side of things at how can we apply these AI models to improve healthcare. So either to identify things in research, such as what symptoms do patients with dizziness experience, or to actually use these models in the kind of the workflow, such as how can we use ChatGPT within medicine to improve patient care or improve doctors' kind of workflows, such that they have less administrative tasks to do.
I saw one study, we're going to talk about it a little bit. This one study where you were looking at you can describe it better. So you're looking at emergency room records, and you were trying to see, could we use ChatGPT to figure out diagnoses, whether it's figure out if, you explain it. Try to explain it better than I can.
Sure. So I guess the pretext to this is, since ChatGPT came out, a number of the UCSF team have done an amazing job setting up a secure kind of interface in which we can send this de-identified patient data to OpenAI via something called an API, which is basically just a computer. And this has allowed us to kind of, in a HIPAA compliant way, use their ChatGPT interface, or we call it something slightly different, but that's the layperson's term for it. And so this spawned a whole bunch of research projects thinking about, how can we apply these to different parts of healthcare? And so one of the areas that I'm quite interested in is the emergency department, because it's the first place in which you go as a patient, typically, if you have a serious medical problem, and it's kind of the front door to the hospital.
Yeah.
And so we took the notes of emergency department physicians, so doctors from the emergency department who have seen these patients, and we sought to find out whether ChatGPT, or its successor GPT-4 now, can assess how unwell is this patient. And so I guess the benefit of this is that if we can improve the timeliness of this type of assessment, i.e. identifying which patient is unwell versus another patient, then we can get them care sooner, and therefore their outcomes are better.
So in practice, I guess this is just early research, but in practice, what could that look like? That could look like if someone shows up at the ER and the registering nurse just types in a couple symptoms, AI might be able to figure out, this person needs to be seen before this person?
So one of the things that we are looking at is how do we... currently, emergency departments are getting overcrowded because of limited resources, aging population, and so forth. And oftentimes, perhaps lesser in the US, but certainly in the UK, there's perhaps a queue even before seeing the triage nurse. And so before there's this risk of, we've got to have a bunch of patients who are queuing and we don't know anything about them. And so, hypothetically, and again, this is very early research, but if we could have some form of interface whereby patients describe their symptoms and are asked questions perhaps by a ChatGPT type bot, and that can be used to flag, say, okay, there is a patient who is number 18 in the queue who hasn't even seen the triage nurse yet, who needs to see the triage nurse now because they've got a big heart attack type thing.
Yeah.
Whereas the number 1 to 17 who've all got stubbed toes
Right.
don't need to see them as quickly.
Yeah. Okay. Yeah, that's interesting. And that does that kind of lead to the one that you presented about the racial disparity a little bit as well? Did that kind of spring out of this search?
Not the interest is just broadly, how do I do things in the emergency department? Which what questions are important questions to ask? And so one of my other areas, which does tie into AI, is that of kind of bias in both clinical care and in kind of algorithmic bias, so AI bias. Mm-hmm. And so the work that I presented was essentially looking at clinical bias. So, we live in a biased society, and there is unconscious bias in all of us, I think. And ultimately, my interest from a healthcare perspective is how do we identify and address that bias? Because, chances are most people don't want to, nobody wants to be biased. Right. They want to treat everybody fairly, especially healthcare providers. But how do we address our own unconscious biases, and what gives us, how do we identify in amongst ourselves when we have that bias? And so one of the things I wanted to do using the large data sets we had was to do that at an institutional level. Mm-hmm. So using both UCSF data and data from another hospital that we have access to, and work out, okay, well, which patients are, and for what types of conditions, i.e., bone problems, orthopedic problems, say, or for pregnant ladies, or what types of conditions do the greatest disparities exist, so that can then inform future research to perhaps address, say, maybe the fact that Black pregnant women are more likely to have a higher mortality rate than white pregnant women. Mm-hmm. Maybe part of that, the origin of that is because of the actual initial assignment of how unwell they are in, when they first come into the emergency department. Because if, say, Black patients are more likely to be assigned as not as unwell than white patients, assuming they come in with the same presentation, then that is a problem that could lead to poor outcomes for that group of patients down the line.
Mm-hmm. Yeah.
And so it's really just kind of combining, again, I very much look at things from a public health perspective of what areas of public health and need to be addressed. And certainly that in the last 5, 10 or so years, there's been a huge shift, which has been amazing, looking at disparities, both kind of everything we term the social determinants of health. So socioeconomic status, whether you have insurance, if you can afford types of treatments. Similarly, racial and ethnic disparities, and other types of, where you live and other things, education level, access to clean housing and so forth. We're slowly beginning to unpick all of this.
Well, that led to this other study I saw, this older study, and then you said you just had a very small part in it, but it's a global study, 82 countries, over 16,000, about 16,000 patients. And so I looked at the list of authors, hundreds of contributors to this paper, but it was looking at that, right? Looking at on a country level or income level of different countries, how does the healing rate or mortality rate after cancer surgery, how is it impacted by the status of care? And what did that paper find?
So one of the, I say I didn't do very much for that paper because I really didn't. Essentially, this is part of one of the initiatives to increase access to research and increase the reach of research. And so this is called a Global Search Collaborative. And by that, it means that there are a bunch of kind of teams within each individual hospital across different hospitals in the UK and also the US, and also a bunch of developing countries and however many countries you mentioned. Yeah. And so I was just one of the data collect. I think I was leading the data collection for Addenbrooke's Hospital in Cambridge. And so I wasn't kind of the brains of the study or anything at all for that. But the benefit of this kind of collaborative study, and one of the reasons why it can be so impactful, is because you have this scale again, and you can find out things across 63 countries or whatever it was.
82.
82, even more. Yeah. That's me as an individual researcher
no way you could
not.
Yeah.
And so, some of the findings was essentially looking at first of all, looking at how does the severity of illness of the condition differ across countries. And so they were finding that, say, and this is perhaps unsurprising, that in kind of developing countries, you're more likely to present later at a later stage compared to in a developed country. And I guess that is very much, well, there's probably a variety of reasons for that, but access to care and kind of the more primary care type model is perhaps some of them. But in addition, they were trying to work out, well, how much of the worse mortality associated with being in a more developing country was because of the later presentation, or are there additional factors such as the delivery of care, almost the systems care, so the systems problems, i.e. how well does the health system run, what perioperative care around in and around the surgery what differences are there between, say, the UK versus more, or in the US versus developing countries, and so they essentially found that it was a combination of both the later presentation, but importantly, there were factors which could be identified and addressed that were specific to the actual healthcare system.
So you were in Cambridge during the pandemic.
Yes.
Was that what was it like doing research? I saw a couple papers come out about COVID and about different things about COVID. What was it like doing epidemiological stuff during a global pandemic? Was it kind of a data science dream, or was it kind of a nightmare? Or what was it like doing research during that time?
Yeah, so my year was the year that kind of we were the class of COVID essentially, and so we graduated early. We technically skipped the final clinical exams. We'd done all our written exams, but we were due to have the clinical exams in May, and we were very happy to not have to do these clinical exams. But then a lot of us volunteered to start work early because of COVID and so forth. And so a lot of the research, I think the main project that I started there was actually it was more public health related than data science related. It was a systematic review looking at interventions to reduce social isolation and loneliness during COVID times. And I think the rationale behind that was I felt that a lot of people were quite rightly looking at the epidemiology, the infectious disease side, how do you prevent, how do you get vaccines and so forth. Yeah. But as is perhaps unsurprising, some of the other aspects of population health, i.e. mental health, was not getting the focus that I thought it would ultimately require, especially if we're going to lock down the majority of the population. Yeah. And so we put together a group with public health, psychiatry, and other faculty, and ran a kind of a rapid systematic review within a couple of months. And it was a lot of work, kind of both practicing like on a COVID ward during my normal working hours, and then trying to organize and run all of this during my free time, essentially. But it got a lot of traction, and I think it's been cited like 180 odd times and viewed like 30,000 times. So it's probably my most impactful piece of work so far. And I guess it just shows I was basically a medical student when I started this. And it shows how, with good guidance, with some professors you collaborate with, and a good kind of core team of people, what can be done together collaboratively, I guess, with everybody working in unison, and what kind of impact you can make. Yeah. So it was an interesting time. Sure. Yeah. But it was well received and got a lot of interest. So I'm glad we did it.
It's almost like I almost forget how scary the pre-vaccine COVID era was. It was like we knew so little, and it was kind of like one of those times. I mean, there's some memes about it too, where like people ignore scientists most of the time until it's like they were saying scientists are kind of like that one smart kid on the group project where you kind of lean on them to do most of the work when you need it, and it's kind of like, that's how we felt about scientists at the time. We kind of ignore them most of the time, but when we really needed them, we're like, okay, we need a vaccine in 6 months, and that's a crazy feat to pull off, but, we look to science, and sometimes, most of the time, science bails us out. So, were you at all worried about catching COVID yourself? I mean, those are early days. I mean, it was kind of a...
Yeah, absolutely. I think one of the most stark moments for me was having, so we graduated, and then I spent probably about 3 or 4 weeks at home with my parents in lockdown, avoiding everything, all content and so forth, as you do, and not having any exposure really to COVID. And then that was all while waiting for our registration to get on it all sorted and so forth. Then I started and was on a COVID ward, and you just kind of like behind these screens, and you think, I've literally spent 4 weeks being about as safe as I can be, and now I'm literally staring COVID in the face.
Yeah.
And I don't know how I feel about this. And it was a surreal time, and there was obviously a lot of sadness and death and so forth. But it was also heartwarming to see people rally together.
Yeah.
And we like that group of doctors who I almost we went through that period together. Some strong bonds were formed, shall we say, and it's amazing what humanity can do when for good, I guess, when you put our minds to it. So
no, I'm sure it's scary but also fascinating at the same time, to be a researcher. So if you would like to learn more about Chris's research, you can find papers that he has written linked to his profile at UCSF. I basically Google Chris Williams UCSF, and you're the one that pops up on those. But there's also the Bakar Computational Health Science Institute website. You can find some interesting papers there. So fascinating stuff. And you have survived our difficult questions, but are you ready for our lightning round?
Yep, go for it.
All right. So, who has more foggy days, San Francisco or London?
San Francisco, but I live near Mission Bay, so we don't get that much fog. But then London doesn't get that much fog either. We just get cloud. So it depends.
So more sunny days here, though, for sure.
More sunny days, yes, definitely.
All right. How about better Asian food, San Francisco or England?
It's a good question. I feel like I'll probably say London or the UK, just because it's like the good food isn't as very, very expensive as it currently is here. So
fair enough. Yeah, no, that makes a big difference, is the price. All right. Do you have a favorite TV show or movie that has researchers or doctors in it?
In the past, I've tended to avoid house and medical things because I've got enough doctor stuff in my life. But the one that This Is Going to Hurt is a book by Adam Kay, which was made into a BBC TV show, and it's I think it's meant to be a comedy, and it has very kind of classic, the sort of humor that you would expect to come out of hospital stories, shall we say. And so that would probably be my pick.
Okay, all right. What was it called? It's
This Is Going to Hurt.
Oh, This Is Going to Hurt. I thought you were just saying This Is Going to Hurt.
No.
Okay, all right, yeah, no, I think maybe humor is the way to go when you're talking about medicine.
Yeah.
All right, so if you were a student back at St. Albans, how would you use ChatGPT?
Well, I mean, I don't know if this is allowed or whether your students do this, but I'm sure there's a bunch of homework that I could do much more quickly. Yeah.
To be honest, we've gone back a little bit to pencil and paper because you can't trust.
Really?
Yeah, you can't trust what people send online anymore. You don't know who's writing it, so.
Interesting.
Yeah.
I mean, it does beg the question. I was having this conversation the other day with somebody who's in education, how the world reacts to new technologies, AI, and so forth, and what do you do?
There are people that are actually quite scared that we're not ready.
Myself included, we're not ready.
Okay. Yeah, we've seen the movies. The movies, it doesn't turn out well.
Well, I don't know. I think this is a wider discussion, but I'm less concerned about Terminator type scenario and more concerned about, say, algorithmic bias. I think there's a lot of here and now that could do a lot of harm with AI if we're not careful with it. And
okay. All right. Coming from an AI researcher, everybody.
That's why I do the research. So trying to prevent that.
Oh, man. Okay. So, hey, if you weren't a doctor or a researcher, what would you be doing?
Probably something more kind of charity or NGO based, I think. I remember back in Cambridge, there's this organization called Charity Entrepreneurship, which is basically like how to set up a charity, take like a classic SF entrepreneur guide and do that for charities. And I guess that I've always been much more motivated by, again, it's the public health impact type thing rather than just making lots of money. And so it'd probably be that kind of social entrepreneurism, I guess is a word for it. But
all right, Abbott Wilson will be proud of you. All right, and we like to end each show by elevating a member of our community by asking our guests to pick an infatuation. An infatuation is anyone in the Asian community that you admire or has inspired you, living or deceased. So, Dr. Chris Williams, who is your infatuation?
It would probably be my good friend and colleague Brenda Mao, who is one of the PhD students in the lab. But she's just fantastic in terms of her work ethic and her knowledge and just everything she does. And so, it's been great to work with her.
All right. What's she working on?
Kind of more computational, similar stuff to me, but more computational side. So she's much more technical, and I'm very much more in the applied space. And she's currently looking at, say, simulations for within the healthcare environment and a lot of stuff that I understand. So, yeah.
You and me both. All right. So is Brenda, you said?
Yeah, Brenda.
All right, Brenda Mao, if you want to come on the show, let me know. You're welcome anytime. All right, well, I think that just about does it for episode number 103. Thank you to our guests, Dr. Chris Williams. Best of luck with everything you're doing. You got new things in the pike. You got papers coming down the path.
Yeah, lots of papers. It's been a whale of a time here, and just having the people around me who can support me to do that has been amazing. So lots to look forward to.
All right. Well, thanks for coming on our show.
Yeah, thanks for having me. It's been a lot of fun.
Yeah, lots of fun. So you can, as I mentioned, you can find out more about Chris at his profile at UCSF. I'll put the link in the show notes. As I mentioned, you can always write to us at infatuasianpodcast@gmail.com. You can follow us on Instagram at infatuasianpodcast. And always follow us wherever you get your podcasts. Whatever you're listening to us now on, give us a follow, please, and you'll know all of the new episodes. So on behalf of Chris and myself, we hope that you're all happy, healthy, and safe out there. We thank you again for listening, and we'll talk to you soon. Bye, everyone.
Cheers. Take care.